Assalamu alaikum. Hello, hello, hello. Likely to discuss about the rheumatology topic. Hope you enjoy. Okay, starts with this question. A 20-year-old football player, he's a football player. What happened that there is right knee pain following a heart attack. Like Messi, Ronaldo, they may fall this sort of injuries and now and then. He cannot bear weight in his right leg. Blood pressure normal, pulse all right. The right knee is deformed, swollen. This is the importance of deformed, swollen, and bruised. And there is the lower leg is warm. The lower leg is warm. Pulse is intact. Knee lateral X-ray of the knee reveals posterior dislocation. There is posterior dislocation, and we can see by X-ray there is posterior dislocation. The shaft of the tibia should be here. This fragment, but uh, it goes forward or it is dislocated posteriorly. So there is posterior dislocation. There is posterior dislocation. In here you can see there is posterior displacement of the tibia relative to femur. This is femur, this is tibia. There is posterior displacement of the tibia related to femur. Immediate reduction performed under sedation. What should be the next step? What should you do? You should look at the pulse. You should measure ankle brachial index. Ankle brachial index, how will you measure that? Systolic blood pressure of the ankle and systolic blood pressure of the brachial. There is the difference between of systolic blood pressure of the arteria dorsalis pedis or posterior artery divided by systolic blood pressure of the brachial artery. The differ the division of these two make a result when it is less than zero point 0.9, less or equal zero point 0.9 diagnostic of the peripheral artery disease. If it is within zero point 0.9 to 1.3, it is normal. If it is more than 1.3, suggests that there is no calcification or incompressible vessels. That's why this happens. So meticulous vascular examination should be done because there is posterior knee dislocation. Posterior knee dislocation. There may be some sort of arterial injury. There may be injury to the popliteal artery. Is the most feared complication of any knee dislocation. Any knee dislocation. What artery? What artery can be? This is popliteal artery. And if there is dislocation, these artery may damage. So in knee dislocation, popliteal artery may damage. So uh, management begins with immediate reduction of the dislocated knee. Uh, Given the risk of vascular injury, these should be followed of meticulous vascular examination, palpation of the popliteal and the distal pulses, measurement of the ankle brachial index, and duplex ultrasonography. If available, duplex ultrasonography should be done. So you need to look for the any sort of vascular injury present or not. So what should be remembered in this question? In this question, in posterior knee dislocation, which artery can be damaged? In posterior knee dislocation, popliteal artery may be damaged. It is the most feared complication. Popliteal artery injury. This is popliteal artery, and in this dislocation, displacement of the tibia, displacement of this tibia may cause injury to this popliteal artery. So in here you should palpate the pulse, popliteal and the distal pulse, and measurement of the ankle brachial index. How can you measure ankle brachial index? Systolic blood pressure of the anterodorsal status and or popliteal artery divided by systolic blood pressure of the brachial artery. The division between these two may cause, mm, if it is less than zero point 0.9 or equal zero point 0.9, it is called peripheral arterial disease. Diagnosis peripheral arterial disease. If it is more than point 0.9 to 1.2, it is normal. If it is more than 1.2, there may be calcification. The combination of the normal pulses with ankle brachial index more than zero point 0.9 virtually exclude clinically significant. Normal pulse and ABI is more than zero point 0.9. Diagnosis done. No significant vascular injury. Any signs of diminished pulse and ABI less than zero point 0.9 of the vascular injury warrant of emergency imaging, CT angiography, and CT angiography, and the vascular consultation. CT angiography and vascular consultation. You should call a vascular surgeon in such a crisis. Okay, in this question, what I am trying to find out, there may be a clue, a key. This is in here. The X-ray of the knee shows a central light illusion, distal femur. It is in the distal femur. This is one clue, and it is moth-eaten appearance. Moth-eaten appearance is a clue for Ewing sarcoma, and it happens in the diaphysis. It happens in the diaphysis, and the moth-eaten appearance happens. When you look at there is central lighted lesion with moth-eaten appearance and lamellated periosteal reaction, which is known as onion skinning. I have heard these a lot: onion peel appearance, onion skinning appearance, lamellated posterior reaction, but it is uncommon moth-eaten appearance. So if you find this in this term, the moth-eaten appearance diagnosis is done. Also in the diaphysis, this is another important features. This is lamellated periosteal reaction, also known as onion skin. Lamellated periosteal reaction, also known as lamellated periosteal reaction, also known as onion skin. And lighted glycerol, off-eating appearance. There is an off-eating appearance. There is cordless triangle, elevated subperiosteal bone, also known as elevated subperiosteal bone. Subbopal appearance, giant cell, eccentric, expansile. Also in the epiphyseal area, this is subbubble appearance, happens in the giant cell tumor. Small round lucences seen. Small round lucences seen in where an osteoid osteoma you should see the small round lucences. Small round lucences where osteoid Back again. Okay. The next question. In this question, what I'm trying to find out a valgus test. Mm, valgus test found in medial collateral ligament injury. Valgus test is negative. So medial collateral ligament sprain or medial collateral ligament injury is intact. Medial meniscus also intact. Prepatellar bursitis. There is a recent onset right knee pain, not above the knee pain or anterior knee pain. There is right knee pain. It developed 2 weeks ago during a training during a training period. During a training period. So, and the pain is in the medial side of the knee. As it is medial side of the knee, so base answerness situated in the medially. Patellofemoral syndrome, it is anterior knee pain, and prepatellar bursitis also anterior knee pain. But pes anserinus is medially present. Pes anserinus is pes anserinus means uh, these three tendons, semitendinous, the gracilis, and sartorius. Uh, these three tendon inserts in an area called pes anserinus, pes anserinus, and this is anserin bursa. This is patellar ligament. This is tibial tuberosity. This is quadriceps femoris tendon. So medial knee pain and focal tenderness has pes anserinus. Uh, so the key point is medial knee pain and focal tenderness has pes anserinus pain syndrome. These condition is often referred to as anserinus bursitis, but most patients do not have true inflammation in the bursa, and multiple regional structure can contribute to the pain. The base and serenus is formed by the conjunct of sartorius, gracilis, and segmental process. The ancial bursa is located anteromedially over the medial tibial condyle. Over anteromedially, the ancial bursa anteromedially over the medial tibial condyle, distal to the joint line and deep to the face and sinus, and distal to the joint line and deep to the face and sinus. Face and sinus pain syndrome can be caused by abnormal gait, overuse, trauma, and management is quadriceps strengthening exercise. And in face and sinus pain syndrome, management is quadriceps strengthening exercise and NSAID. It is used abnormal gait, overuse, or trauma. Abnormal gait, overuse, risk is obesity, diabetes. Risk is obesity, diabetes, knee osteoarthritis, angular deformity. Patient experience localized pain over anteromedial tibia, which is exacerbated by pressure on the opposite knee. Pressure on the opposite knee when lying on that side. Pressure in the opposite knee when lying on that side. There is tenderness over the medial tibial condyle just below the joint line. In meniscal tear, there is Thessaly test. Patient rotates the body to side by side with knee in 20-degree flexion and foot is planted. Knee 20-degree. Patient is rotated side by side with knee in 20-degree flexion and foot is planted. Meniscal tear, McMurray test. This is McMurray test. Okay. Postural versus Schwarman kyphosis, and postural hyperkyphosis and Schwarman kyphosis. This kyphosis, postural kyphosis is flexible, corrects when the patient bending forward uh, and in supine or prone position. Patient bending forward or supine or prone position. And Schwarman kyphosis vertebra with an anterior aging vertebra with anterior aging. There is wedge-shaped Schwarman kyphosis is rigid. Kyphosis is rigid. Does not correct when bending forward. Kyphosis is rigid. Does not correct on bending forward. Does not correct on bending forward in supine or prone position. Does not correct in bending in supine or prone position. Diagnosis of Schwarman kyphosis requires lateral spinal X-ray. Lateral spine X-ray. This is normal for a six spine. This is normal. This is anterior version of the vertebra. Anterior version of the this is version of the vertebra. This is Schwann's kyphosis. The patient has a back associated with kyphosis, a hunched appearance during excessive curvature of the usually thoracic, leading to abnormal forward rounding of the back, abnormal forward rounding of the back. The way to help component elevation of the kyphosis, what is more specific. In adolescent, kyphosis is typically due to slouching or poor posture. Postural kyphosis is due to mainly bony abnormality. The kyphosis is not rigid and the kyphosis correct in supine or prone position. However, the patient's kyphosis does not correct, which is concerning of Schwarman's kyphosis. If the kyphosis is more than 50 to 60 degree bracing and surgical intervention may be warranted. Bracing and surgical intervention may be warranted. Schwarman's kyphosis, bracing and surgical. So this is a very tough question. A 13-year-old boy mid back pain, dull, non-radiating pain. What should I look? If improves with rest, this pain improves with rest and acetaminophen. Another report is that the boy he is always hunched and never stands straight. The patient do not recall any moderate thoracic kyphosis and exaggerated lumbar lordosis are present. Kyphosis persists in supine and prone position. This is higher in Schwarman kyphosis persists in supine and prone position, but in postural kyphosis or hyperkyphosis or normal thoracic vertebral posture kyphosis, in here this uh, this will be corrects when bending forward in supine or prone position, corrects when bending forward in supine and prone position. Okay, question number 4. Okay, this patient, on examination, she has tenderness to the gentle palpitation over the or her neck, shoulder, and back. Everywhere is pain, pain, pain. It's maybe fibromyalgia, exercise program, and aerobic condition. Widespread pain index and symptom. Widespread pain index and symptom. Seven-year-old boy, right leg pain. Her mother says that he is running around the house and fell on the bathroom an hour ago. Mm, the patient has been crying and experiencing thigh pain. He did not hit his head and lose consciousness. Medical history is notable for three fractures after seemingly minor injury. Minor injury, there is fracture. It might be osteogenesis imperfecta. There is hyperlaxity. Another uh, problematic information: hyperlaxity of the joints, hands, and upper extremity. It happens in Ehlers-Danlos or Marfan. Heart, there is no heart feature. X-ray fracture and proximal femur and does not involve the growth plate, which appears normal. Does not involve. So there is lots of fracture of the femur also, multiple tree fracture due minor injuries, so osteogenesis imperfecta, most probably. Why it is not Ehlers-Danlos? In Ehlers-Danlos defective type 5 chromosome, these defects patients to have giant hypermobility but no recurrent fracture. In here, there is joint hypermobility, there is no hyperlaxity, there is sublaxity, hyperlaxity, but no, there is in here, there is no recurrent fracture, but in this, there is a recurrent fracture. So, osteogenesis imperfecta should be in the mind too. Due to defective collagen in osteoid extracellular bone matrix, often begin having frequent fracture from minor trauma once they become mobile around age 1. Many patients with osteogenesis imperfecta have dentinogenesis imperfecta, and opulscent blue-gray and yellow brown pulsing blue gray or yellow brown discoloration of the teeth caused by discolored dentin. By discolored joints are often hypermobile due to ligamentum laxity. Joints are often hypermobile. In-ear joints may be hypermobile due to ligamentum laxity. Scleral thickening can lead to scleral thinning. Scleral thinning can lead to blue sclera. There is blue sclera. There is scleral thinning. So there is blue sclera. There may be hearing loss, short stature, lots of thing happens in here. Lots of thing, lots of thing happens in here. 17-year-old high school student comes to the 17-year-old high school student comes to urgent care with right shoulder pain. The pain has started after he hit his shoulder on the ground while tackling another player during a rugby game. On examination, there is no gross deformity of the shoulders or the adduction of the right arm across the torso elicits pain over the superior shoulder. Adduction. SA joint sprain. Adduction of the right arm elicits pain over the superior shoulder. Range of motion of the arm is intact. So AC joint sprain, pain over AC joint, passive adduction provokes pain. Passive shoulder adduction provokes pain. Passive shoulder adduction provokes pain. In AC joint sprain, passive shoulder adduction, passive adduction of the right arm across the torso elicits pain over the superior shoulder, so it is AC joint sprain. In biceps tendinopathy, pain over the bicipital groove, rotator cuff, rotator cuff tendinopathy, pain with abduction and external rotation. Uh, Strength is preserved. In rotator cuff tendinopathy, strength is preserved. In rotator cuff tear, pain, weakness is present. Pain with abduction, and external rotation, pain with abduction and external rotation. Adhesive capsulitis, there is decreased active and passive range of motion, and in AC joint sprain, passive shoulder adduction provokes pain. Passive shoulder adduction provokes pain. When you go passive shoulder adduction, when you find passive shoulder adduction provokes pain, adduction of the right arm across the torso, elicits pain. So it is problematic. Adduction of the right arm provokes pain. It is problematic. If you find such kind of X-ray, this is avascular necrosis or osteonecrosis. And the risk factor of this also excessive alcohol use, sickle cell, femoral head fracture, glucocorticoid. These are the subchondral sclerosis and loss of sphericity, MRI, serpiginous low intensity line T1 one meridian subterminous osteonecrosis of the femoral head. This is osteonecrosis of the femoral head, flattening or collapse of the femoral head, femoral head. This is patchy sclerosis. Keep osteoarthritis, subarticular sclerosis, loss of joint space, subarticular sclerosis, loss of joint space, osteophytes. If auditory or woman comes to the emergency department, severe back pain following a fall, he tripped while getting out of the car or landed on the back. The patient has 20-year history of ankylosing spondylitis for which he takes prescribed medication regularly, but he has never had pain similar to this. Examination shows midline tenderness over the upper lumbar region. Midline tenderness of the upper lumbar spinal range of movement is restricted. There is no sacroiliitis. Midline tenderness, age less than 45, has 20-year history of ankylosing spondylitis. Why this pain? Ankylosing spondylitis patient now midline tenderness over the lumbar region. Midline tenderness over the lumbar region. Spine range of movement is restricted. So vertebral fracture should be thought. Vertebral fracture or osteoporosis should be thought. Although ground level fall, the unlikely cause of fracture, otherwise in a healthy man, the clinical suspicion of the vertebral fracture should be much higher. The vertebral fracture should be much higher in patients with AS. Patients with long-standing AS can develop osteopenia or osteoporosis due to increased osteoclast activity in the setting of chronic inflammation. In the setting of chronic inflammation, mediated by TNF alpha and interleukin. In addition, spinal rigidity in this patient can result from minimal trauma, although finding improved thoracic weighting and hyperkyphosis, thoracic weighting and hyperkyphosis. Acute lumbosacral radiculopathy can occur due to disc herniation. Acute lumbosacral radiculopathy can occur due to disc herniation, although it is seen in degenerative spondylolisthesis. Lumbar radiculopathy is related to the lower lumbar region. Patients with primary or metastatic malignancy can develop pathologic fracture following in-hole trauma. 20-year-old office requesting a refill of opioid medication for new onset left with pain. Pain started here 3 weeks ago. She is she has sickle cell disease with severe hospitalization for acute pain crisis. So sickle cell patient pain or restriction of abduction and internal rotation of the hip. Think about the osteonecrosis. Sickle cell patient having lots of opioid pain, but they have propensity of having avascular necrosis. They have the caliber of having avascular necrosis. They are like non-Otsuko. They are like spirited away. Osteonecrosis. Have you seen Spirited Away? A great film from Ghibli made by Hayao Miyazaki. Osteonecrosis. 11 is clubfoot. The patient has clubfoot. Molding class application to the feet should be the next step. Congenital clubfoot, abnormal development of the talus bone. Initial uh, initial management of the congenital clubfoot is gentle manipulation and stretching with minimal serial molding cast. Gentle manipulation and stretching with serial molding cast. Stretching with serial molding cast. Ideally beginning in the neonatal period once an optimal position is achieved by casting. Long-term bracing is typically required. Long-term bracing is typically required. Surgical correction is reserved for refractory cases. Surgical correction is reserved for refractory cases and recurrence of the clubfoot after non-surgical should be treated. Uh, if untreated, clubfoot leads to abnormal weight with weight bearing. In ankylosing spondylitis, 6 months ago, intermittent pain that responds well to the naproxen. The patient has progressed now throughout the day and he no longer relieved with naproxen. So next you should do is to go TNF. TNF alpha inhibitor. Since the injury, he has been unable to abduct the arm without severe pain and difficulty. Unable to abduct arm without severe pain and difficulty. Acute rotator cuff injury, positive drop arm test, abduction and external rotation, lateral shoulder pain, decrease active range of motion, decrease abduction and external rotation, physical therapy, and consider surgical repair. Consider surgical repair. This is dislocation. Uh, sorry. The, in here, what happens? Active and passive range of motion is decreased. Mm, Decreased active and passive range of motion. So diagnosis done. Adhesive capsulitis. There is reduced forward flexion of the lumbar spine and the tenderness over the crease. Reduced reduced forward flexion of the lumbar spine and tenderness over the lumbar superior. So diagnosis done. Ankylosing spondylitis X-ray of the SI joint should be X-ray of the SI joint should be done. Carpal tunnel nerve conduction study should be done. This is hip osteoarthritis. This is hip osteoarthritis, subarticular sclerosis, loss of joint space, and osteophyte subarticular sclerosis, bone articulation হয়, subarticular sclerosis, subarticular sclerosis, 14-year leg pain, bilateral ankle, knee, elbow, wrist, mouth swelling, tenderness, and palpitation. There may be GIA type of thing. What sort of GIA this is? There is a systemic feature. Mm, the pain spreads to knee, elbow, wrist over past last month. The aches worse in the morning, improve the day, the pain or ache uh, worse in the morning and improve the day prior to this. The patient has been sedentary and and spent most of her time indoors watching television. In addition to The In addition to the walking routine, she has transitioned to a plant based. She has transitioned to a plant based diet. The patient the patient felt tired. The patient felt tired, and most days the patient felt tired most days, and despite sleeping 9 hours a night, her weight has improved from 95% to 90 over 3 months. Bilateral ankle, knee, elbow, wrist have mild swelling and tenderness to palpation. Which of the following medication have the most appropriate on this condition? Naproxen, GIA, painkiller, some sort of painkiller, naproxen. This is GIA, bilateral ankle, knee, 4, 6, 7. Polyarticular. This is polyarticular artery more than 5 joints. Very complicated with uveitis. Very complicated with uveitis. And oligoarteries less than 5 joints may be complicated with uveitis. This is appendix and joint space narrowing. Osteoarthritis, persistent and exercise. In here, bilateral atrophy of the quadriceps, bilateral atrophy. This is rheumatoid arthritis. The two most prevalent form of arthritis, osteoarthritis, rheumatoid arthritis. He, the patient has the knee pain and stiffness are pronounced right side, worse in the morning, but he gradually improved in the afternoon. After the he takes no medication. Review of the system is positive for fatigue. There is mild bilateral atrophy of the quadriceps. Review of the knee reveals and strengthening around the erosion and soft tissue swelling. In RA antiplatelet medication, methotrexate should be started in here. Any joint affected are morning stiffness, fatigue, systemic symptoms, soft tissue swelling, multiple joint are more consistent RA than X-ray covers of the diagnosed periarticular erosion, distal osteopenia, and soft tissue swelling. So her morning stiffness, systemic symptoms like fatigue, soft tissue swelling, fatigue, soft tissue swelling, and multiple joints are consistent with RA, consistent with RA. Anti-V1 RN can anti-nuclear antibody positive. In CDD, there may be SLA, systemic sclerosis, polymyositis, and rheumatoid arthritis. These four. This is a simple question, but I missed. SSLA, systemic sclerosis, polymyositis, SSPR, SSPR, SLA, systemic sclerosis, polymyositis, and rheumatoid arthritis. And in O2 ankle rule, there is pain. Patient can plant her legs, and patient can plant her with the dorsiflex. Sensation normal. There is a lateral aspect of the right ankle has swelling. Uh, Ottawa ankle rule. This is Ottawa ankle rules. When you shoe extra of the ankle, when you do extra of the foot. Pain on the malleolar zone. If there is pain on the malleolar zone, if the pain is in the midfoot zone, is in the malleolar zone, now do extra of the ankle. If pain is in the midfoot zone, pain is in the midfoot zone, so do X-ray of the foot. Malleable do extra the ankle, midsole do extra. Modern smart law thought in the fourth. What is degenerative joint disease? Older older patient. Examination shows pain with passive internal rotation of the right hip. Increasing pain increases with activity. In osteoarthritis, that means mechanical pain increases with activity relieved with rest. In mechanical pain like osteoarthritis, it is increases with activity and relieved with rest. This is important. And the older age patient, most likely osteoarthritis, should be taught. Slowly progressive pain relieved by rest, degenerative disease, joint disease, osteoarthritis of the hip should be thought. This is a degenerative disease. In autoileal atherosclerosis can cause lower extremity pain with activity, In neuralgia, parasympathetic compression of the lateral venous nerve. In cerebrospinal electrophoresis, what should be? Osteoporosis common for spinal women, calcium, initial complete blood count, metabolic calcium 25 hydroxy vitamin D is aimed to ruling out secondary causes bone loss. Mm, in addition of non-classes, there is anemia, hypercalcemia, not that anemia, renal failure, creatinine is high, there is hypercalcemia, most likely older patient more than 45, osteoporosis, multiple myeloma should thought, be thought. Uh, there is splenomegaly moderate RA patient with leukopenia. He has what? The small joints of the hands are swollen, defaults. He has joint pain, swollen, and there is splenomegaly generalized lymphadenopathy, no sinus symptoms. Diagnosis done RA and RA Peltier syndrome. In Duchenne muscular dystrophy, echocardiography should be done to look for Duchenne dilated cardiomyopathy. In Duchenne myopathy, dilated cardiomyopathy, echo should be done. Disruption of the bone vasculature, vascular necrosis, having history of taking oral glucocorticoid, major leg compartment in acute compartment syndrome. Looking for compartment increasing compartmentation. The patient has severe lower extremity pain worsened by stretch of the calf muscle, given likely the crash injury and the use of antiplatelet inhibition, which can cause compartment syndrome. This is osteoarthritis, and you can see joint space narrowing. This is hand osteoarthritis. This is hand osteoarthritis. Very reduced joint space subcontinental sclerosis. Osteophytes present. Osteophyte present narrow joint space. Subcontinental sclerosis. Osteophyte. Indigenous spread of infection of the femur. Indigenous infection. So in osteomyelitis, spread infection. In osteomyelitis, there is indigenous spread of infection. The patient's leg pain, refusal to bear back, fever, leg pain. Mm, mm, able to bear back, leg pain. Several leg pain, refusal to bear back. Diagnosis done. The skin of the overlying right proximal femur is slightly swollen and CT scan of the clavicle fracture. For CT chest. Lung thoracic trauma. Clavicular fracture. He has concerning of hemorrhagic shock. Mm, presentation of fracture associated injury to the supplement vessel, fracture associated injury of the so patient having clavicular fracture. Look for do the CT scan of the chest. Why is there is injury of is there is injury of the subclavian vessel? Injury of the subclavian vessel. Is injury of the subclavian vessel. Antibiotic in septic arthritis. Mild swelling of the joints of the hands and wrist. There is fever. Right knee is more swollen. Swollen. Active and passive range of movement is problematic. Fever. Acute myelitis. Joint range of motion problematic. So septic arthritis should be thought. In reactive arthritis, the genital lesion plus genital lesion plus arthritis. Reactive arthritis, arsenal of the genital lesion. Area carcinodermatitis. There is a circumferential side. The genital lesions carcinodermal is painless. Superficial ulcer. So it is reactive arthritis. Radial head subluxation. Right part of the right forearm. 4-year-old child forearm pronation not moving his extremity after being swung by arms. This is radial head subluxation, common injury of preschool age children. So 4-year-old on emergency dependent did no moving his right arm, nursemaid's elbow or right radial head subluxation. The patient was behaving and moving normally when he awoke in this morning. The father is awfully swung her by hands and suddenly started crying and refused to use her right arm. The patient played like previously, but it usually makes her laugh. The patient physical examination vulnerable why the right arm is extended and downward, with forearm pronated and averse moving. Though so it is not nurse. Mm, Hyperconnection of this is hyperconnection of the hyperconnection method. Price stabilization. Slip capital femoral epiphysis. This is the key point when the hip is flexed. Hip remains in the this is the key. When the right hip is flexed, there is external rotation of the hip. In neuralgia, parastatic reassurance and conservative therapy. Avoid tight non-opioid anticonvulsant and nerve block. Multimodal pain management in amputation. The distal stump is non-tender and palpation. This is serum sickness like diffuse rash in the arms. This is shearing of the proximal fascia, split capital femoral epiphysis. This is split femoral epiphysis. And that's all. Hope you enjoyed.